And as I promised you, let's talk a little bit about the emergencies. And I have this lecture on YouTube, but unfortunately, I have only Arabic version for it. So I will try to record this one and also post it on the YouTube so you can go back for it. As I told you, if you don't have time to do anything for this exam, do only emergency radiology. I put at the end of the lecture a list of the emergency books, emergency radiology books that I took the images and I took the content of the lecture from it. So at least scan some of them. Scan like see the images, see the topics, refresh your knowledge. Don't read every single sentence and stop at it and try to review it many times. No, there is no time for that, unfortunately. And the exam style will not ask you like that. Okay? But please, please, please do your best in the emergency radiology part. Where is the lecture available? It is on YouTube by the same name, like it is Safe Radiologist. But it was Arabic version. I will try to record this in English version and I will post it on YouTube also. You want the file? See how much you will pay me. Okay, let's go quickly through the the slides because it is a little bit lengthy, but maybe 80% of the slides are images only, so it will not take a lot of time with us. I meant this lecture meant to be only refreshing for you before the exam, and I may miss some of the emergencies, so don't miss them. Add them or even text me. I will add them to the lecture. But please think about emergencies. Always be obsessed. You know, the obsessive compulsive disorder. Be obsessed in the exam by emergencies. Don't be obsessed by anything except emergencies. Really, even in the X-ray, even in ultrasound, even in a very simple case like pancreatitis, bowel obstruction, anything, any disease. Each disease has its emergencies. Definitely, a patient with simple bowel obstruction, the management is different from a patient with bowel obstruction with perforation, and different from a patient with bowel obstruction with perforation because of a tumor, and different from other cases. So each case, even if it is the same disease, but they are different. Simple pancreatitis is not like pancreatitis with abscess or pancreatitis with pseudoaneurysm and active bleeding. It is very different. So please be obsessed with emergencies in each case. Don't forget that. Let's go quickly and this is my short message. The content, I try to cover all modules. And let's start by the head and spine. First of all, the fractures. The fractures are crucial because of what could happen from the fracture. And not all the fractures are the same. If it is simple fracture, it is different from the depressed fracture. It is different from a comminuted fracture or displaced fracture. It is different from a fracture reached the temporal bone and reached the internal ear, the middle ear ossicles. See, it is different. So the management is different. So please don't take things lightly. Okay? Post-operative cases, nobody knows. Don't ask this kind of questions. Nobody knows. Anything could appear in the exam. Really, nobody knows. Try to be confident and try to organize your answer. Try to give a reasonable answer and don't forget the emergence. This is my advice for any case. Okay? So the fractures are different if it is depressed, if it reached the canal, the auditory canal, or the carotid canal, or anything like that. So please, not all the fractures are the same. Always try looking for the emergencies, for the complicated ones. because it will change the management. Okay, then the brain tissue itself, the contusions. Where should you search for the contusions? At the bony protuberance, like the base of the anterior cranial fossa, at the anterior temporal fossa, at the base near the tentorium cerebelli. This is the most common uh, sites of brain contusions. And also, don't forget, it is only simple brain contusion or not. It is complicated by something like mass effect or hemorrhage, or and you have to do a follow-up imaging. So if it is increasing, so it is emergency. So not all the cases are the same. This is large one. See, the brain contusion increased in less than 24 hours. So this is a very emergent case, and you can see starting of the midline shift, and this is stuff we will talk about now. Also, it is only contusion, or there is element of epidural hemorrhage or subarachnoid hemorrhage. So don't forget to search for the related findings, the extension of the disease, where it is and where it goes. You have to give a good description overall. Okay. And again, this is some kind of the hemorrhages, and we will talk about the mass effect shortly now. Another sort of emergency in the brain imaging is the diffuse axonal injury, and it has specific sites. So you have to search for these specific sites. Once you suspected diffuse axonal injury, you have to look for the corpus callosum, you have to look to the basal ganglia, the thalami, and the gray-white matter junction. And you have to look for them and mention them. Don't mention thoroughly that there is multiple hyperdensity in the brain. This is not a good answer. You have to mention exactly what is the site or the location of the abnormality. Okay? And you have to know what is the next step, and always mention it. What will happen in your daily practice when you suspected the diffuse axonal injury? You will talk to the referring physician directly through the phone urgently now, inform him about the situation, and recommend doing MRI. Which sequence is the best? The SWI. So you show your knowledge, you show your safety, and you give them a completed answer. Okay. Then again, multiple examples of diffuse axonal injury with some scattered subarachnoid hemorrhage. So the traumatic brain injuries sometimes came one sort of it alone, but sometimes it has multiple types of traumatic brain injuries. Okay. Then this is all the areas of diffuse axonal injuries with some sort of subarachnoid hemorrhages, and also another examples of traumatic injuries. And again, see, when you look to the gray-white matter junction, when you look to the brain stem, you will find this hyperdensity. So you know where exactly is the abnormality, and you go search for it. It is like that you know your home, where you put your keys, where is your shoes, where is your phone, where is the phone charger, where is your clothes. You know everything, where exactly it is, and you go directly to take it from its location. So you have to do that also in the cases in the exam, and even in your real life. Because sometimes if you didn't go specifically for the site of abnormality and look for it, you may easily miss it. Again, this is the third type of emergencies here in the brain is the subarachnoid hemorrhage, the famous subarachnoid hemorrhage, the hyperdensities in the sulci, and always look for the extensions. The subarachnoid hemorrhage, the subarachnoid space contains CSF. So it is very easy to find redistributed blood anywhere in the brain, subdural, intraventricular, in the cistern, the basal cistern, anywhere. So please try to look for all of the sites of the abnormality, because sometimes it will give you a clue. Like this area has subarachnoid hemorrhage, so you may change the window to bone window and find a fracture. If it is mainly in the basal cistern, so you will look closely to the vessels, you may find aneurysm. If there is it is located around only this area, you may find a mass. There is a mass, and there is bleeding from this mass here. So please go and look for the exact location for it. And a lot of examples about the subarachnoid hemorrhage. Here it is mainly in this area, and they found aneurysm in this area, in the MC, right MCA. And all of the CSF spaces, it is opened for together. So in any part there is hemorrhage, it might try, go to the rest of the CSF spaces. So try to look for all of them. And there is a lot of examples, like I told you. Sorry for that. I don't know why I have this cough. Give me one moment. And how it looks like in the MRI, the best sequence is the flare, T2 flare. Don't forget that subarachnoid hemorrhage also, the susceptibility weighted image sequence also is good, especially in hemosiderosis, that the lining of the sulci are all sidrotic, are all blooming because of chronic subarachnoid hemorrhage. And it can cause symptoms like seizures or headache or this kind of stuff. This subarachnoid hemorrhage is around the basal cistern, so you will look for the aneurysm and accordingly. Uh, another information, don't forget or don't miss the pseudo subarachnoid hemorrhage. So it may look like the subarachnoid, the true subarachnoid hemorrhage, but the main difference between them is the brain tissue itself. In the regular true subarachnoid hemorrhage, the brain tissue is still preserved. So there is still gray-white matter differentiation. But in pseudo subarachnoid hemorrhage, you will never found gray-white matter differentiation. So don't forget that. And how to manage a patient with aneurysm. You know about that. So you will do emergently a CT angiogram. If it is negative, you may repeat it in 48 hours, or you may request a conventional angiogram according to the situation. And at the end, you might also find that the conventional angiogram is negative also sometimes. Okay. Then also another topic, it is looks like the subarachnoid hemorrhage sometimes, so I put it together with it, is the tuberculous meningitis. Dr. Sami Khan sometimes mention it in his lectures. I know it is not so common in UK, but it is common in our countries. Also, it might happen with the patient with HIV and this kind of immune suppressed status. So it is not uncommon. So it's worth also mentioning or know about it and how to differentiate it from the subarachnoid hemorrhage. Okay, the immune status, the history of the patient, and it is always in the around the basal area, the basal cistern, the tuberculous meningitis. Also, it easily cause early hydrocephalus, the tuberculous meningitis. And in post-contrast images, you will find diffuse meningeal enhancement in tuberculous meningitis cases. Okay, and this is the pattern of the enhancement, meningeal enhancement. And there is some information about the tuberculous meningitis. The normal study in the early phase, in the unenhanced images, you will find meningeal thickening and increased density in the basal cistern. In the post-contrast, you will find meningeal enhancement, early hydrocephalic changes. It may precipitate or lead to venous thrombosis, as this is infection usually can cause thrombosis in the vessels, in the nearby vessels. Look for the source of the infection. It might be near in the mastoid or in the sinuses or anything like that. Hydrocephalus may be the only presenting feature in some cases, and you can ask for CT venography. And please, 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 always ask for MRI brain according to the case, with contrast or without contrast. But don't forget to always mention that, because CT head is only a screening tool. Don't forget this information. Like the X-ray, it is a screening tool. If there is any positive finding in the CT head, we always check it with the MRI brain because it is more obvious and it gives us the detailed findings of the disease, the extensions, and this stuff. Okay. Then we will move to the fourth topic in the emergencies here in the brain, the diffuse cerebral edema. I just talked to you about it. And one of the signs is the pseudo subarachnoid hemorrhage. But the diffuse brain edema is very important according to the age of the patient. Don't forget that. And there is a nice link on Radiopedia about the normal brain according to the age. Because the young patients, there is no parenchymal volume loss, so the brain is very well occupied and the sulci is very narrow and this stuff. But the old patients, the old people, usually or normally, normal process for them is to have parenchymal volume loss and large sulci and ventricular system. So if you found the vice versa in the young patients, you found that there is dilated ventricles or sulcite, so this is abnormality. Or in the old age, you didn't find dilated ventricles and sulcite, so it might be edema. So don't forget that. And you don't have to wait for the full-blown picture of the disease, that the patient is irreversibly brain death. You can look for the early signs of the abnormalities, especially the CSF spaces, the basal cistern and the CSF spaces. There is some examples of the diffuse brain edema with loss of the gray-white matter differentiation and the white cerebellar sign, and all of these kind of cases. Also, don't forget the reversal sign of the basal ganglia hypodensity instead of normal hyperdensity. The pseudo subarachnoid hemorrhage we just talked about. Okay. Also, another type of injuries is the counter coup. So sometimes there is an obvious abnormality on one side, but there is a hidden abnormality on the other side. So don't forget to look for it, especially around the bony protuberance. Okay. Then the extraaxial hemorrhages, the most common two are the extradural or epidural, and then the subdural. Extradural is always most of time associated with overlying skull fracture, the bone fracture. The importance of extradural hemorrhage that it is by itself per se is emergency, even if it is small, because it is rapidly growing and it causes significant mass effect, even if it is still small in size, like 1 or 2 centimeters only, it can cause significant mass effect. And it can increase dramatically in very short period of time. So epidural hemorrhage is always top priority in management and emergency. Don't forget to give a little bit more attention to the signs of active bleeding. If they give the patient contrast in the exam, you may find the leakage of the contrast and doing this swirl sign, famous swirl sign, or the differential density of the blood itself. It may also give a clue that this blood didn't happen at once, it is going on. So some of the blood is hypodense, some of the blood is hyperdense, so it is still ongoing bleeding. And always look for the signs of the mass effect. First, the midline shift, then the types of the brain herniation, and I will show you some of the images shortly about the brain herniation. See the bony part of the problem and the scalp, the overlying scalp. So don't forget all the abnormalities. See, this one is very small at the anterior temporal location. And even this small one can cause significant mass effect. So don't forget that. And also another example of counter-coup injuries. See the differential density here and the early signs of the brain herniation. And I will talk shortly with you about that. See the differential density again. Okay, so the simple epidural hemorrhage has management. The epidural hemorrhage with brain herniation has a different management. The epidural hemorrhage with active extravasation and swirl sign has a different management. Different by the mean of how aggressive you have to intervene with this case urgently. Okay. The subdural hemorrhage is a little bit more common, especially in old age. You might find it sometimes bilateral. You may find it sometimes chronic. The chronic ones are really bad in imaging because of the isodensity and this is stuff you know about. So pay more attention to the periphery of the brain. You must see the brain tissue adherent to the skull. See, it is adherent, stick. Even there is volume loss, even the sulci are prominent, but the brain, the gyrus, is adherent or very near to the skull. Any space occupying something there that efface or displace the gyrus or the brain tissue away from the skull, this is exactly what the subdural hemorrhage would do. See, anything, even if it is very thin film here, it pushes the brain tissue away from the skull. So don't forget that. And don't forget the subdural window, 200, 100, window width and window level. Always mention it to the examiner, if even if he didn't bring the image for you. But mention that in my routine practice, I do that. Then the subdural hemorrhage can extend along the falx or the tentorium, can cause also significant mass effect like the epidural as well. This is the isotense stuff I just talked about it to you, that there is no clear brain tissue adherent to the skull, see, compared to the other side. And then there is effacement of the ipsilateral lateral ventricle starting to have midline shift and also some sort of brain herniation. We will talk about it now. So the subdural hemorrhage, sometimes the patient has the two types of abnormalities. So like it has a component of extradural and another component of subdural. So also pay attention to that and don't assume that all the hemorrhages are the same. No, sometimes he has two types of hemorrhages and you have to mention them and describe them separately. This is acute on top of chronic. This how it extends to the falx and the tentorium cerebelli. Also, here the signs of the brain herniation. Also, we will mention them shortly now. This is the pneumocephalus after the intervention, after they take the drain the hemorrhage or put like a VP shunt or something like that. It is expected, or if there is any fracture, it will cause it also. So don't look for it. And don't forget to see how it looks like in the different modalities. The CT, the MRI sequences, you have to be familiar with it. Then the brain herniation, you have 3 or 4 main types of brain herniation for in real life and in the exam situation also. The brain herniation, external one, is mostly through a fracture or there is a craniectomy. They did a surgery and removed the part of the calvarium and the brain may herniate through it. But the other 3 common things is the subfalcine, then the uncal, then the tonsillar, cerebellar tonsillar at the basal, at the foramen magnum. So let's see one by one. The subfalcine, this one, the subfalcine herniation. What is the best clue for subfalcine herniation is the effacement of the frontal horn. Okay, this is the whole lateral ventricle is effaced, but effacement of the frontal horn specifically is a very good clue for subfalcine herniation. And what is the problem if there is subfalcine herniation? The brain tissue compresses the ACA, the anterior cerebral arteries. So it is very crucial to detect it very early because if you miss that, the patient will have even bilateral ACA infarctions. Then the uncal herniation, and what is a good clue? You have 2 clues really for the uncal herniation. One of them is the basal cistern effacement. You cannot see the basal cistern. And the other clue is very funny. I don't know, I have image for it or not. Uh, I wish I have image for it, but even you can see it anywhere. If you look for the ipsilateral cerebellopontine angle cistern, the CPA cistern, if you look for the ipsilateral CPA cistern, you will find it dilated. Why it is dilated? Because the brain herniation will push the CSF in this ipsilateral side downwards. So it will bulge. It is also an early sign of ankle herniation. So the basal cistern, you cannot see the basal cistern, or the ipsilateral CP angle cistern is starting to bulge, starting to dilate. So this is also an early sign. Okay, because the ankle herniation, to imagine that there is part of the brain, the medial temporal part of the brain is herniating through the tentorium downwards, or sometimes the cerebellum upwards herniate, but you have to have something in the posterior fossa, like hemorrhage or mass or something like that. But the common thing is the the ankle or tentorial herniation, and it pushed the CSF downwards, so it bulged the CP ankle. If there is anything in the posterior fossa, so it will cause ascending, but it has also the same concept. Is midline shift? No, it is not the same. I told you this. A lot of cases it has midline shift, but without subfalcine herniation. The crucial finding is the effacement of the frontal horn. So always look for the effacement of the frontal horn, effacement of the basal cistern, and the foramen magnum effacement or crowding. Okay. Then the tonsillar at the foramen magnum, the cerebellar tonsillar herniation, you have to see the spinal cord clear fluid around it. There is clear fluid all over the space around the spinal cord, but here you can see the cerebellar tonsillar herniation, and it is very severe type of herniation because the whole brain is herniating now. Okay. Uh, this is you have subarachnoid, you have subdural, you have midline shift, and you have here subfalcine herniation. Also, there is basal cistern effacement, so you have also ankle herniation. So all of types of the abnormalities you have it here. There is some diffusion restriction because of the brain herniation. When it herniates through the tentorium, it effaces which vessel? The posterior cerebral artery. So it will cause PCA infection. So you have to know this kind of information as well. Okay. This is the normal. This is the midline shift with subfalcine herniation, and also it can cause entrapment syndrome. You will find that the contralateral lateral ventricle is dilated, so the ipsilateral effaced, and the contralateral is not dilated. This is usual, but when the contralateral start to dilate, like the temporal horn and the lateral ventricle, so it is called what? It is called entrapment of the left or of the contralateral ventricular system. This is the subfalcine herniation. See the effacement. This is the normal frontal horn displaced, but it is not effaced. Here it is effaced, so there is subfalcine, and it caused the ACE infarct. Here the early ankle herniation, okay, and the basal cistern will start to collapse, and this is again the ankle herniation also. What could be vascular emergencies in the brain? Sometimes if it is with contrast, so there is dissection, there is complete occlusion. You don't know if there is any fracture near the foramina transversarium of the vertebral arteries, so it might increase the risk of dissection. So always be aware about that. The aneurysm, especially around the bleeding sites, the left carotid cavernous fistula or the carotid cavernous fistula, it has to be traumatic, and you will find that the ophthalmic vein is dilated. Uh, Also, what else? See how it looks like in the the MRI, the flow void of the aneurysm is very big. If there is any tumor, it will enhance. Sometimes it looks like each other on CT. The venous sinuses, the venous sinus thrombosis, it is very important, real life and exam scenario. And always look for the extension of the thrombosis, to what extent. Okay. Always search also for the underlying cause and expected complication. So make your thinking process always like that. You find the abnormality. What could be underlying cause of it? Here in the venous sinus thrombosis, you might find nearby infection like sinusitis or mastoiditis. You may find a mass like meningioma or something. You may find a overlying bone fracture. Okay. So, and the expected complication is the brain tissue itself, if there is any venous infarct or something like that, how it looks like in the CT, in the MRI, CT with contrast, MRI with contrast, a lot of stuff. You have to train your eyes on it. This is the dissection, how it looks like in the post-contrast CT or in the MRI. Also, uh, see the dissection flap is here. This is the basilar tip with dissection also in the left carotid. This is aneurysm with bleeding. This is subarachnoid with this is the venous sinus thrombosis with the deep cerebral veins. Don't forget them because it will cause bilateral thalamic infarct, and this is important stuff. Then the stroke, all of you already know about the signs of the stroke, the hyperdense vessel sign, the loss of gray-white matter differentiation. Compare on the other side, you will find it obscured here. Or also the stroke can cause mass effect. It can cause brain herniation. It can cause hemorrhagic transformation. So you have to search for the expected complication for every disease. And don't forget this arterial vascular map, especially the ACA, MCA, PCA, and the ICA, PICA, and superior cerebellar. The main things, the basal cistern, the thalami, you have to save them by your heart. Okay. It looks, this is all only for differential diagnosis purposes, that sometimes the infarct may looks like the herpes simplex, but the herpes will always uh, preserve the basal ganglia. Okay. And the herpes could come bilaterally also. Infarcts usually come unilateral also. So don't forget to mention these items in your description so the examiner know that, oh, you are talking about the infarct, you are talking about herpes and this stuff. Early involvement of the medial left temporal lobe or the medial part of the temporal lobe in general is favoring the herpes simplex. For spine, what could be emergencies for spine? The most important and common thing is the prevertebral abscess. And always don't forget the vessel. And what is the cause? The cause is maybe there is a foreign body here. There is a discitis osteomyelitis here. So always search for the cause and the expected complication. And how it affects the airway. It compresses the airway completely or not. Because each case has different management in time wise. It reached the base of the skull, the base of the tongue and the mouth. So it is very crucial now because the airway is really compromised. Okay. Also in the spine, try to comment on the exam or in the image in a wise manner, that don't judge that it is soft or it is not clear or something like that, but mention the basic stuff that you should cover the whole area that need to be imaged. Like if it is cervical spine x-ray, you have to see from the base of skull till the C71 vertebral body, because here they imaged only C6, and then when they included the whole cervical spine, they found a bilateral facet dislocation. This is emergency. And don't forget always for the fractures and dislocations, the difference between stable and unstable. One column is stable, two column is unstable, because they have to put a collar, neck collar, and they have to do the MRI and take the patient to OR emergently, not like the stable fractures or dislocations. Hangman, the atlantoaxial dissociation. I try to put most of the emergencies I am aware of. And don't forget also in the atlantoaxial dislocation, the flexion and extension view. But please ask the patient first if he has any history of rheumatoid arthritis, because the patient easily will have atlantoaxial dissociation and may injure the cervical spine. The traumatic cases, see the base of skull is far from the C1, C2. So there is here atlanto-occipital dissociation, and this is very bad injury. And always look for the brain tissue and the spinal cord in this kind of cases. Uh, Again, we talked about that. What else? The always check the posterior elements. As I just told you that one column is stable, is okay, but two columns or three columns is not okay. So any injury that will include the two columns or three columns is uh, unstable and very high risk of spinal cord injury. Like this case, you can see the spinal cord itself is has abnormal signal. And the fractures, if there is any retropulsed fragment compressing the spine or not, if there is epidural component, hematoma or abscess or anything. So don't forget the emergency. Not all the cases are the same. Okay. Here you see that even in the axial stuff, you can see the spinal canal very compressed. So don't forget to put it in your checklist. Here that is discitis osteomyelitis with epidural abscess extension, and here also the epidural abscess and this stuff, and the abscess, how to differentiate between the abscess and the phlegmon. The abscess is fluid, the phlegmon only enhancing tissue, so the DWI will differentiate between them. A lot of information you already know about them, but you have to uh, make a roadmap or like a mindset for the important stuff, so you don't you will not forget them in the exam. You already know them, you already organized them, and it is easily to recall in the exam. Finally, also the spinal cord infarct, how it looks like, and this stuff. We are done with the first part, the CNS and the spine. We may take only maybe 5 minutes or so to to take a small break for all of you. If you want to do something, you can do it, and then we will come back. Okay? Hello. I see you are still here. You are true warriors, guys. There is a question about the phlegmon and abscess. Yeah, phlegmon will enhance only, completely enhance on post-contrast images. And on diffusion images, there will not be diffusion restriction. But the abscess, the peripheral, the wall itself will enhance, and the center of the abscess will restrict the diffusion. Okay, I hope it is clear. So let's continue. Sorry if it is a little bit lengthy lecture, but I will go as fast as I can. So let's finish it. For the chest and cardiovascular stuff, what could be an emergency? Always think like that. What could be emergency? So you will search for them. In apparently normal CT chest, apparently normal, always check your hidden areas. Like what? Like the aorta itself, the aortic root, the aortic wall, the aneurysm, and this stuff. The pulmonary arteries, especially the segmental branches, if there is embolism. The coronary arteries, if there is anomalous course of the coronary between the aorta and the pulmonary artery. If there is any pericardial hematoma, effusion, or intracardiac thrombus or mass, search for the pneumomediastinum, pneumoperitoneum, or acute osseous fractures. So I try to summarize the hidden areas as much as I can, and everyone also can add anything. Recording not started. Oh my goodness, really? Why? I feel it is started, guys. Yeah, see progress. So Let's continue. Start by the vascular stuff in the chest. The most important, the most crucial thing is the aorta. There is no aortic knuckle. There is veiling of the hemithorax. There is effusion. Sometimes there is apical cap. All of these are signs of the aortic injury. And most of the cases, unfortunately, die very soon. Other cases or other examples for aortic injury. See also the widening of the mediastinum and this stuff. See the spinal fracture is very close to the aorta. It may give you a clue that the nearby aortic arch is injured. Here see the dissection. And also, by the way, for the dissection, you as I told you, for all the diseases, not only the dissection, you have to summarize the findings, the set of findings that may come in this case. So as example, for the dissection, what is the first question? Where it is start and where it ends? Where is the beginning and where is the end for this dissection? Because it will change the management. I always concentrate on this specific part. Anything will change the management is very important to the patient and also as well very important in the exam. So where it starts, where it ends. And is there any more emergent signs like what? Like bleeding, there is active bleeding or not? Like the major branches of the arch of aorta, the carotid, the subclavian, and this stuff. The major branches of the abdominal aorta, like the celiac, the supramesenteric, the renal, the inframesenteric. Are they affected or not? Were arising from the false or the true lumen, because if they arise from the false lumen and they are not affected at this moment, but they may be affected very easily in the very short period of time. Okay. Then the solid organs, are they affected or not? There is kidney infarct, splenic infarct, there is anything, bowel infarct, anything like that. So you always think about the set of findings and go and check every single one of them. Okay. There is always, if there is effusion or fluid around the dissection or around the aortic syndrome, check the density, if it is dense or not, because if it is dense, it is very likely to be blood. And also it is top priority emergency. See the size of the aorta here in the X-ray and in the CT, how it looks like, and also apply the questions that we just mentioned about the dissection. The type A reach the ascending, so it is surgical. Type B is only medical management. See the major vessels, the brachiocephalic and the subclavian and the carotid. They might be affected or not. So pay more attention for this kind of findings. See the celiac here, see the renal there. So it is very, very important. And this, what I just talked to you about, the kind of questions you have to answer them in your answer. You have to mention all of these things in your answer. Here, if there is any fracture in the clavicle or in the upper chest, don't forget to mention the vessel because it may affect the subclavian, right or left. Also, there is a lot of causes like the cervical rib or hypertrophied scalene muscles, or there is pancreatic tumor. There is a lot of causes, but don't forget always the vessels, especially the superior vena cava subclavian will cause swelling of the upper limb or swelling of the head and neck, the face and the neck and the upper chest. So always be familiar with this kind of history. Look for the veins, the pericardial effusion, the barrel-shaped heart, the or even on the lateral, the double-shaped, the cookie, Oreo cookie sign on the lateral. Always check the lungs for any signs of heart failure like pulmonary edema, pleural effusion, and this stuff. See the pericardial effusion, the cardiomegaly, and the early enhancement of the veins, the hepatic veins, and the IVC, because this is signs of more important thing is the cardiac tamponade. So pericardial effusion is emergency, but cardiac tamponade is more than that. So always, even the emergency has levels of intervention or of treatment. So don't forget to always look for emergencies. Some kind of pulmonary embolism, they might be very small like that, even in distal, a little bit distal branches. Always with pulmonary embolism, what is the set of findings with pulmonary embolism? Where is the embolus? Exactly, right and left, upper and lower. And the heart. How is the heart? There is a thrombus in the heart, there is a mass, there is a heart strain. So you must comment on the heart in pulmonary embolism cases. So this is the normal intraventricular septum, the straightened, and the bowed. This all the degrees of the heart strain. Again, the straightening and the leftward bowed. How to recognize cardiac tamponade on imaging? As we saw, the heart itself, is constricted. The ventricles are not in their regular size, and there is no flow to the heart. No flow to the heart means that the contrast will stay in the superior vena cava or inferior vena cava like that. There will be severe from the history also, the severe hypotension and this stuff. So don't forget that. For the bones, what are the emergency according to the bones? The rib fractures. So what is more important in rib fractures? The flail chest. So flail chest is emergency because it is paradoxically moving. With inspiration, it goes down to injure the lung. So it will continuously injure the lung. It will cause pneumothorax. It might cause serious injuries. Okay. The always the first rib and second rib, if they are fractured, always you have to ask for CT with contrast to review the main vessels, the major vessels, because it is a high impact injury, and the vessels could be easily injured also. For the sternum also put it in your checklist because sometimes we missed it. And see the soft tissue hematomas with active extravasation. So please don't forget the soft tissue hematoma is, you can take it very lightly, but sometimes it is very serious in rectus sheath muscle or like here in the breast or in the gluteal area or anything. So the hematoma itself is a good finding, but ask yourself what could be emergency finding or red flag in the hematoma itself. Okay. For the air, the pneumothorax is emergency, but the tension pneumothorax is top priority emergency. How to know that there is tension? Look for the diaphragm, because sometimes the mediastinal shift is not so evident, but the diaphragmatic, the flattening of the diaphragm is a very good sign on the tension pneumothorax. Again, this is the tension pneumothorax. You have to drain this air instantly now in the radiology department. So this is very top priority emergency. Even in the scout, you can see the tension pneumothorax. Even if it is abdominal X-ray, you can see the tension pneumothorax. And don't confuse it or overcall it with uh, uh, the deep sulcus sign. It is not tension pneumothorax. The deep sulcus sign, yeah, the patient should be supine, and the pneumothorax, the air will be there in the CP angle, but it is not tension pneumothorax. The diaphragm is not flattened, and here there is a scoliosis, so it is not mediastinal shift. So please take care of these small things in the description. The diffuse subcutaneous emphysema is always a clue for the main airway injury, like trachea or main bronchus injury, and also it is emergency situation. Don't forget, especially in the kids, the inhaled foreign bodies, and it will cause trapped air in the expiration in the side of abnormality. The pneumomediastinum with a lot of signs of the pneumomediastinum, and you will see a lot of images in the Eagle Eye series also about the pneumomediastinum. I try to put it here. How to differentiated between the true pneumomediastinum and the pseudo pneumomediastinum or MASH effect. That the true pneumomediastinum, the visceral pleural line is very crystal clear, sharp on the medial mediastinum, in the medial pleura, and there is a crescent air overlying it. So this is a good sign of pneumomediastinum. And always check if there is any air in the lower part of the neck. So it is a good clue that there will be pneumomediastinum here. So don't forget to link between these two signs. Here also another sign, the continuous diaphragm sign, the air under diaphragm. Always look for it on the right side. It may occur on the left side, but don't rely on the left because the gastric fundus may look funny, the splenic colon may look like that, and this is stuff. Okay. Left diaphragmatic rupture, and you can find some of the bowel retrocardiac and high in the chest. And here the stomach is herniating to the chest also. So it is different from the hiatal hernia. The hiatal hernia should occur in the gastroesophageal junction at the opening of the diaphragm in the midline. So this one is ruptured. And do you know the name of the hernia? If it is posterior paravertebral, its name is Morgagni, and it is more likely to have complication like bowel obstruction. Then in the abdomen, what could be emergencies? The vascular stuff and the traumatic stuff, and here more inflammatory stuff like the cholecystitis, appendicitis, pancreatitis, and this is stuff. Okay. For the vessels, again, I told you about the psoas muscle shadow and the aneurysm, the aortic aneurysm, and the crazy emergency findings of the aneurysm. The aneurysm itself is emergency, but what is the size of it? If it is more than 5 centimeters, so it is more emergent. If there is any fat stranding around, if there is any signs of rupture, if it is dragging on the vertebral body, if there is a nipple, if there is break in the calcification of the wall, the atherosclerotic calcification in the wall, all of these are signs of more emergent or more urgent situation than the regular aortic aneurysm. Okay. Again, this is the aneurysm, and don't forget the major vessels, how it looks like, and the solid organs, they are affected or not. See, there is a hemorrhage inside the wall. There is a thrombus, and there is a hemorrhage inside it. So also it is uh, a red flag for impending rupture. Okay. And this is the dragging, and this is the ruptured and the bleeding. And this is aortocaval fistula. It is not that common, but fistula between the aorta and the vena cava. Sometimes there is a fistula between the aorta and the bowel, the duodenum or the small bowel, especially if it is saccular aneurysm, like the inflammatory aneurysm, if there is any nearby discitis, osteomyelitis, or nearby infection anywhere. So this is more easy to fistulate to the nearby organs. Inflammatory emergencies, the cholecystitis, how it looks like, the thickening, the pericholecystic fluid, or the tension of the gallbladder wall under the abdominal wall, the ruptured gallbladder with perihepatic collections, if there is a stone at the neck, or the stone like the Merizzi syndrome, or the stone is inside the duodenum with a fistula, or the stone is in the cystic duct or common bile duct causing biliary obstruction. So there is a lot of scenarios related to this stuff, but be aware of all the possibilities. So you will go and look for them. Here, see the tension of the pneumothorax, the cholecystitis, sorry, and there is air inside the gallbladder. So this is sign of emphysematous cholecystitis. Emphysematous more common in diabetic patient, and it needs urgent drainage now, right now. The patient cannot wait. The patient cannot even do surgery now. You should drain them first. The pancreatitis, how it looks like, the sausage-shaped pancreas with peripancreatic fluid or fat stranding. What is the expected complication of the pancreatitis? Like the vessels nearby, thrombosis or pseudoaneurysm. The bowel may have some ileus around. There is abscess, there is necrosis, there is fistula, a lot of possibilities, and you have to search for them. Okay? See, this is a case of pseudoaneurysm here, necrotizing pancreatitis. It is very emergent, and you have to put multiple drains right now. The fistula, if there is any fistula between the pancreas with the stomach or pancreas with the bowel, like this case. The pancreatic abscess, it is only localized area of collection with air and fluid components, and you have to drain them. Sometimes they put the drain through the stomach and the abscess drain to the stomach directly, or put the drain percutaneously according to the site of the abscess. If there is any nearby extension of the infection, like splenic abscesses or liver abscesses, or even portal vein thrombosis or splenic vein thrombosis, all of this could happen with the pancreatitis. The famous and common appendicitis with the appendicolith, and it can cause also perforation, localized abscess, or ileus, or even it can cause liver abscess with portal vein thrombosis. So always uh, check the liver in any abdominal inflammation. Check the liver and portal vein. Diverticulitis, pancreatitis, appendicitis, all of this stuff can affect the liver. Okay. So there is portal vein thrombosis here. In appendicitis case, this is the appendix. So don't forget to include all of this stuff in your search pattern. And finally, the colitis, the lead pipe and thumb printing. The bowel obstruction also is very common exam scenario. And please, you should write down from now the set of findings for these common diseases. If I found a bowel dilatation, how I will answer the case? First, I will ask myself which part of the bowel is dilated. Is it the large, the small? Is it the whole small or distal small, or only proximal small, or only duodenum and stomach, or only the esophagus? So, because each one of them has a scenario, a different scenario. So please ask yourself which part of the bowel is dilated. Then it is dilated till where? So the whole proximal bowel is dilated, and till what part? Where is the transition point? And at this transition point, you will find the cause. So the cause will be adhesions, volvulus, mass, vascular occlusion, hernia, anything. But stick to the approach. Then, after you find the transition point, start searching for the expected complications like wall strangulation, wall loss of enhancement, and ischemia and perforation with free air, free fluid. All of these are expected complications in bowel obstruction. And always don't forget to check the vessels, even if they are not the cause, but make it a habit that in every single case I will check the vessels. You may develop a good approach, especially in long cases. Like in this quick look, I will take a general look for the whole scan. Then I saw the main abnormality. Then I will go to the main abnormality and start describing it, how it looks like, where it is exactly, what is the extensions, the underlying organ, how it looks like. If there is other side, so I will mention it. Then the lymph nodes surrounding it. Uh, then I will have a general look on the images only for vessels. See, I will take a general look again from the first cut to the last cut in less than a minute, but I will only look for the vessels, dedicated look for the vessels. And then I will look for the rest of the organs. I will look for the bone. So try to make it like slices, like parts. I have five steps to finish the case. In each step, you are looking for something different and dedicated for this thing only. Okay, so the dilatation and then the transition zone and then a lot of causes, searching for them, and a lot of signs for each cause. The pseudophysis sign is a good clue in the small bowel obstruction for the transition zone. The signs of strangulation in the wall itself, what happened to it, and don't forget to look for the common causes for the bowel obstruction. Then some information you all know about it, the transition zone, the coronal. I know the coronal is much easier, but don't ask for the coronal before you finish the axial, because the axial is front of you, and you have to answer it. You have to find abnormalities or search for abnormalities in the axial first. Uh, don't forget the closed loop if there is any previous surgery, the pseudo obstruction, especially in the large bowel, the Ogilvy syndrome, if you still remember it in the old patient with large bowel dilatation but without signs of obstruction, uh, and all the other causes. I think if you saw the abdomen X-ray in eagle eye, you will find also a good amount of slides about the bowel obstruction itself. You can go back for it also. The ischemic obstruction, the closed loop obstruction, and some images for it. This is the small bowel feces sign. And always look for the periphery of the film of the image to see the large bowel is dilated also or not. So it is only small bowel dilatation or large bowel dilatation as well. See that descending colon and the ascending colon is collapsed, because it really will take the case to another scenario or another level. How it looks like the strangulation. See the normal bowel wall enhancement and the abnormal bowel wall enhancement. So always compare and train your eyes with this kind of stuff. The Weirle sign, the famous Weirle sign for closed loops obstruction or volvulus. It is a very specific sign for it. The pneumatosis intestinalis is the gases inside the wall, and this is early stage before perforation and strangulation, and it is always associated with portal vein gas. And the string of Pearl sign, it indicates that this obstruction is a little bit uh, in late stage, like the whole bowel is filled of fluid now. There is no air fluid level because the whole bowel is filled of fluid. So this is a later stage in obstruction. Here, the wall, the target sign of the wall for strangulation, the spoke wheel sign for closed loop obstruction. Uh, See the in supine radiograph it is negative. There is no bowel obstruction, but uh, in the erect or in the CT you may found signs of obstruction. So always you do the X-ray only for screening, but if you have clinical sure signs of obstruction, go for the CT. Okay. Also, in later stages in the bowel obstruction, it may look normal that the whole bowel is filled of fluid, so you will not find any air fluid levels or string of Pearl sign on X-ray. So the whole bowel is filled of fluid already now. So even that will not uh, will not cancel the bowel obstruction and will not exclude the bowel obstruction. Okay. Here also there is the transition point, the transition zone, how to find it, the small bowel, the colon, always in the periphery, how to localize the parts of the bowel. This is important. Also, again, some images. This is hernia, inguinal, femoral hernia if it is around the femoral vessels, inguinal hernia if it is near the scrotum or medial to the pubic tubercle. Don't forget the obturator hernia. Also, it is very common to cause bowel obstruction. Okay. Then the adhesion, that there is no specific cause, but you can see there is a transition zone and you don't know what is the cause. There is previous history of surgery or so. So the cause would be adhesions. Here, don't forget the masses. See the mass in the wall. This is also important. Here there is a hernia in the wall, but this is not the cause of the obstruction because the cause is here. There is a cecal carcinoma. So don't rush and take your time. Sometimes the patient has long-standing hernia and it is not the cause. So don't assume and go and search specifically for the cause. Here, the intussusception, the common intussusception, always in adult, it is associated with underlying mass. This is the target sign of the intussusception and the crescent sign in X-ray. The gallstone, see the gallbladder wall and the stone is in the bowel itself, and you can see it in the X-ray. Uh, the inguinal hernia, how it looks like. The femoral hernia is along the femoral vessels and it is more common to cause complication. The obturator hernia also between the obturator muscles and it always cause complication. And see how to localize the hernia if it is lateral like that. So it is femoral here, the obturator, and more medial is the direct and indirect inguinal hernias. The vessels, especially in the abdomen. Really don't forget to look for the vessels. The celiac, the superior mesenteric, the inferior mesenteric, the arteries and the veins. Don't forget all the vessels to look for them. Also, don't forget always in the serious inflammations or serious traumas or serious obstruction to look for the signs of hypovolemic shock because it is different and it needs also urgent intervention, urgent fluids, and this stuff. Like the most common one is the collapsed IVC, as you know. The bowel wall edema, the adrenal hyperdensity, the IVC is collapsed, the kidneys hyperenhancement, all of these are signs of hypovolemic shock. The large bowel malignant emergencies, the most common things is the sigmoid and the cecal volvulus, so don't forget them. The apple core appearance of the large bowel or the colon adenocarcinoma, especially in the rectosigmoid stuff. How to differentiate between the sigmoid and the cecal. The sigmoid has classic signs on the X-ray like the diverging lines to the pelvis. There is dilated descending colon. There is paucity of gases in the pelvis. So coffee bean appearance and this stuff. Sigmoid volvulus can occur and recur in the old patients with redundant sigmoid. So they might try first with a rigid sigmoidoscope to relieve the volvulus. If it is very recurrent or if there is any other signs or if there is a mass or something, they will do surgery for it. The cecal and see the swirl sign for the volvulus part. The cecal volvulus is different and it is always dangerous because the cecum will not volvulate unless there is underlying mass or serious problem. So always check for that problem, do CT and search for it. And again, don't forget the signs of the inflammation of the colon, like the thumb printing or lead pipe appearance or the toxic megacolon with the islands of mucosa in the inflamed tissue. Then the pneumoperitoneum, it is very easy. The famous one, the regular sign, and always look for it on the periphery of the film, not on the overlapping bowels. It will give you the pseudo-regular sign. Okay, and air under diaphragm, the decubitus appearance, especially the right side is up, so the air will accumulate along the liver border, so it will appear, stands out very clear. And don't count only on the left side because it might be confused with the gastric fundus and left colon. There is a lot of other signs like the triangle of air, subhepatic triangle of air, or the also continuous diaphragm sign, or there is a rounded lucency in the middle of the abdomen. There is a lot of signs for pneumoperitoneum. What could be emergency in trauma? Always look for the active bleeding or laceration reaching the hilum or signs of shock or signs of devascularization of the organ. So this is really needs urgent intervention by interventional radiology or even general surgery. So know the signs of emergency at least. Okay. Here you can see the active bleedings, and it is also here in the conventional angio. And don't forget the hypovolemic shock. See the IVC is very collapsed. Don't forget the biliary injuries and the urinary injuries. So it is not only blood, it is not only vascular injuries, but in the liver, don't forget the biliary, in the kidneys, don't forget the urinary tract. Okay, and this is the famous HIDA scan for checking the biliary leak to check if this is biliary injury or vascular injury. See the infarct here in the kidney. So see the spleen reach the laceration reach the medial aspect with small hyperdensities there. So it may increase the possibility of active extravasation. So always check for emergency. Look for emergencies. Don't forget them. See a lot of splenic hemorrhages here, and they can control the bleed first by embolizing the splenic artery proximally. So they decrease the blood flow to the spleen, give it some time to calm down, to quiet the active bleeding, and then they can deal with it surgically. Don't forget the pancreas, the midline. See the laceration here in the midline. The duodenal hematoma, also see that pancreatic body and tail. Sometimes there is also active extravasation in it. In any collection, soft tissue, abdominal wall, muscles, back, mesenteric, in any collection, always search for the active bleeding signs. Okay? Duodenal injury will always cause retroperitoneal stuff like retroperitoneal hematoma, retroperitoneal air, and this stuff. What else we have? Again, active extravasation in the mesentery. So always look for them. See the kidney and the perirenal hematoma. Don't forget the urinary system. See, this is perinephric hematoma with air because of the trauma, and see the fluid here also in the mesentery. The renal petechial. See the kidney shut down. There is no blood flow there. So this is emergency. Don't forget that. See the hematoma with active bleeding. So always in the hematoma or any collection, look for the active bleeding. Here is urinary injury. See the excreted contrast is going to the perinephric hematoma, so it is coming from the urine. So don't forget that also. The pelvic fractures, always check for the urinary bladder injury. Is it extraperitoneal, going to the soft tissues, or intraperitoneal, between the bowel loops? The adrenal hemorrhages, also it is common in the traumatic cases. See the emphysematous pyelonephritis, emphysematous infections. So pyelonephritis per se is emergency and they need IV antibiotics and fluids. Emphysematous pyelonephritis, it will need drainage also. Pyelonephritis with obstructing stone causing end-stage xanthogranulomatous pyelonephritis, it will need surgery and nephrectomy. See, there is a lot of different management according to the situation. So you have to search for these findings, for these items. The ovarian torsion and testicular torsion is very common in the exam and also in the real life. Always the ovary is contains a peripheral follicles. Okay, so if it is enlarged, engorged, edematous without blood flow, so always suspect ovarian torsion. Testis as well, also the heterogeneous appearance of the testis with loss of the vascularity, so also it is dangerous signs. Okay. Uh, again, this is the ovary, and the ovary, you know the ovary by the peripheral follicles. Always know the ovary by that. See the difference between the size of both ovaries. So don't forget the torsion. And the torsion, uh, does not necessitate that the ovary migrate to the other side. It may torse on its own side. So take care of that. Any free fluid with engorged ovary, with pain, and this stuff, always high alert of a ovarian torsion. Okay, this is the normal testis, the normal vascularity, and the abnormal vascularity. And don't forget the Fournier gangrene. And the most important place that the infection extends to is the perineum. So you can find emphysematous infection in the subcutaneous tissue, or the scrotum, or anywhere. But this is yes, emergency, and it needs drainage and antibiotics. But once the infection extend to the perineum, the patient should go to the OR now directly to do surgical debridement for all the inflamed tissue. Okay. Then finally, the musculoskeletal cases. The most common emergencies in the musculoskeletal are charcot joint, like that, disorganized. There is debris, there is dislocation, there is increased density. And this is per se. If it is only neurological cause, you will put the foot in the cast for 3 months and it will heal in its own. But what is more dangerous, what is more important, if there is underlying infection with osteomyelitis. So this is very important to exclude, because if it is infection, so it will need also debridement, especially in diabetic patients. And never ever forget the osteomyelitis with all of its signs, acute or chronic. And if it is near a joint, so please make sure that it didn't extend to the epiphysis. Like here, see the epiphysis is cloudy, because it will affect the growth, and it may extend to the joint itself. So there might be septic arthritis. So this is also emergency. So there is also levels inside the emergency. Not all the emergencies are the same. Okay. Then the pediatrics, the most important thing in pediatrics is the non-accidental injuries. And review the pediatric eagle eye video. You will find a lot of images about the non-accidental injury, the clavicles, the ribs, the corner, the metaphyseal corner, or different ages of the fractures, or the patient has subdural hemorrhage, or non-ambulatory kid with lower limb injury or lower limb fracture. All of these are classic signs of non-accidental injury, and you have to call the physician immediately now and inform the child protective services in the hospital, and all of this stuff you know about. Okay, what could be other emergencies in the pediatric age group, like the germinal matrix hemorrhage in the premature infants? This is how it looks like in the ultrasound, especially in the codothalamic groove, or the hypoxic ischemic encephalopathy, especially in the basal ganglia, bilateral thalami, posterior circulation, brainstem, all of these areas. Don't forget the Meckel's diverticulum in the pediatric age group, and we talked already about the appendicitis and the intussusception also in the pediatric age group. So all of this might be emergencies. And here the common pathology that may occur in the premature patients is the necrotizing enterocolitis. Necrotizing enterocolitis, also you'll find it in the pediatric video of the eagle eye in the YouTube. Necrotizing enterocolitis may start only with ileus. Then it may progress to the pneumatosis intestinalis, then the portal venous gas, then the free air. All of them are stages for the necrotizing enterocolitis. And once you suspected it, you should put the patient NPO, give them IV fluids, antibiotics, and a series follow-up X-rays at least every 6 hours or 12 hours according to the clinical situation. This is the free air, the pneumoperitoneum in the kids, in the infants, with the famous falciform ligament sign. The pneumomediastinum signs in the pediatric age group is a little bit different. So don't forget the Spinnaker cell sign, right or left. And always, if there is any air in the soft tissues here, always look for the pneumomediastinum. Okay. And again, also again, the ovary and testis in the kids as well as the adolescents. And this is the list of the books. Uh, you don't have to go through all of them, but you have to cover all of the emergency cases from any place, Radiopedia, textbooks, anywhere. But always think about emergencies. I'm so sorry that the lecture is a little bit take more time than we expected, but we had some discussion about the short reporting in the beginning. I hope you enjoyed the lecture, you get benefit from it, and I hope we can meet in other lectures or other sessions in the future. Okay. Have a good luck, all of you. Try to reach to me directly or through the group if you have any questions. I hope you pass the exam in the near future. Okay. See you and bye bye.